Good evening, everyone. Welcome to tonight's meeting of the Health and Social Care Scrutiny Review Group. Start with the administrative stuff. The meetings this evening will be live streamed to the public. A recording of the meeting will be available on the Council's website within 24 hours of the meeting. Would members and officers please remember to switch microphones on when speaking and speak directly into the microphone and switch microphones off when finished. We don't have anyone joining via Teams, and usual thing about mobiles, switch them off or place on silent. Okay, apologies for absence.
Apologies from Councillor Begum and Councillor Ahmed, who is being substituted by Councillor Latif.
And Councillor Steer substituting. Oh, I beg your pardon, Councillor.
You need to welcome me as a new
member.
Okay.
Yep, just to welcome Councillor Steer to the committee.
Chowdhury is now on the exec, so
yep.
I'm taking her place.
Okay, thank you and welcome. Minutes of the last meeting. Those who were at that meeting, is that a fair and true record of the proceedings of that meeting? Thank you. Disclosures of interest?
None, Chair.
Urgent business?
Again, none, Chair.
References from committees and other bodies?
None, Chair.
Chair's update. I have nothing to report on anything that's happened since the last meeting. Okay, we're going on to our first and only report this evening. Update on maternity services at the Luton and Dunstable University Hospital. David?
Thanks. David Carter, Chief Executive of Bedfordshire Hospitals. I'm just going to give a very quick introduction and pass over to my colleagues who will introduce themselves. So I think just first thing to say, I think it's a very exciting time for maternity services at L&D because next month we move into our new block, and that's been a long time coming. So our new maternity and neonatal unit is now finished and we're ready to get in. In fact, the first two parts of that new unit are already occupied. That's critical care and our surgery and theatres. So it's a really, really exciting time for us. And really important, particularly because we know that we're one of the few trusts which have a growth in our births. And indeed, Luton itself has the highest fertility rate in the country of any local authority. So it's really important our maternity services are fit for purpose, and they have been very challenged. And indeed, the Luton unit is the largest maternity unit in the east of England. So it's really, really important that we get it right. And I think we're on a good path to get back to where we need to be. And I'll hand over to Emma first, who's going to explain some of the work we're doing. So, Emma.
Thank you, David, and good evening, everybody. I'm Emma Hardwick, and I'm the Director of Midwifery at Luton and Dunstable, Bedfordshire Hospitals. I'm just going to go on talk about a few things that we've been doing to enhance our maternity services, to improve the experience of both our patients but also our staff, because clearly we look after our staff well. They can look after patients. You can't look after people if you're not looking after yourself or being looked after. We've done a number of things over recent months and years. Definitely, as David has explained, we're so excited to be moving into our new block. I wish I could show it to you. It's absolutely beautiful. It's what our patients and their families and staff deserve. Our strengthened governance and safety oversight is really important, and we've been working aligned to national direction, have introduced a perinatal quality surveillance model, which is important because it's a mechanism for escalation and for being able to see trends and things when they may be changing either in a positive direction or not so that you can intervene. And we've also developed a quality assurance framework which provides us with really clear detail of our oversight of governance mechanisms. Clearly our workforce is really important, and like many other units, we have struggled in the past to maintain our workforce, and we've reported to you previously about that, and really pleased to say that we have been able to recruit midwives, and while we still have a few vacancies at the moment, with our newly qualified midwives, 21 arrived on Monday, and another few over the next few months, our vacancy rate will be quite small. We've also recruited some other specialist midwives, for example, midwives for patient experience, for managing our flow. As David explained, we're a very, very busy maternity unit, and managing our risk of women going through is so important. So we've recruited some additional midwives and some additional very experienced doctors to be able to manage that. One of the things women say to us is that they find it difficult when they're waiting, they're not quite sure what's happening, and there are delays, and that actually having some good flow through with senior colleagues being able to coordinate that, we know that will help. We also have been really focusing on our complex pregnancies and women with perinatal mental health conditions. We know that the prevalence of this is very high across the UK, and Luton is no different. And with our vulnerable populations and our demographics, we know that caring for these women is really important. And we're just about to go out to advert for a midwife role leading for our very diverse demographics to help us target interventions for this group of women. We also belong to Maternal Medicine Network and Fetal Medicine Network, so of course targeting women with most need. Clearly, we've talked about our staff, and we know that previously we have had some challenges about the culture within our department in maternity services, and we've worked really, really hard with our trust colleagues and developed some really good mechanisms of listening to staff, and they have contributed to the development of anti-racism and civility charters, which we are rolling out and trialling within our units. And then alongside this, the investment in training and clinical standards is really important. So again, informed consent is really important mechanism, and really important for women to feel listened to, as Amanda will speak about shortly. And so investing in our staff through all of the training they're doing to not only just understand the skills, but the application of that through the human factors and working as a multidisciplinary team is most important. And we're really fortunate to have a really dedicated maternity and neonatal voices partnership across our trust, and we have colleagues who working with us and working on the targeted interventions, so we can be responsive, and they can be a sort of intermediary for us with our service users. So I will hand over to Amanda now.
Thank you, Emma. Good evening, my name's Amanda Swong. I'm a clinical psychologist, and I'm the clinical lead for the Ocean Service. So the Ocean Service is a maternal mental health service, and although we are sited operationally under Perinatal Mental Health Services within East London Foundation Trust, we operate clinically operate in a very integrated way with the maternity systems across Bedfordshire and Luton. So we're comprised of specialist midwives and perinatal psychology, and we provide 3 pathways. One is for women and birthing people who've experienced loss for any reason. The second is for people who've experienced birth trauma, and the third is for those who are experiencing tocophobia. Tocophobia is a severe fear of childbirth due to previous experiences of loss and trauma. And our referrals, I think, reflect the very sort of close working relationship we have with the maternity services, and sort of over 45% of our referrals come from our maternity colleagues. I'm going to talk specifically about the tocophobia pathway, because that's the pathway that most sort of directly, I think, addresses the prevention of birth trauma. So people come into this pathway where they've had a previous adverse experience or outcome from a previous pregnancy or birth. And these are the people who are most at risk of further trauma and further adversity. And our specialist midwives lead that pathway, but it's also a pathway in which we deliver psychological interventions as well. And we aim to provide, I suppose, a restorative experience of pregnancy and birth and in fact through the healthcare system. Often people who come into this pathway have had their confidence in healthcare and in the NHS shaken, and we aim to provide something that is a different experience to that, and obviously to give them a very different experience of pregnancy and birth. And the vast majority of people who go through that pathway do report that they experience their birth in a much more kind of, they have much more agency, it's a much more positive experience, and most people who come through that pathway no longer need specialist intervention, don't need specialist psychological support for trauma after it. We also are very aware of these sort of very significant health inequalities that exist in pregnancy and birth, and particularly within our Luton populations. We currently have an active quality improvement project which is led within the LGBTQI sort of sector, but also includes in our steering group specialist midwives from the Hospitals Trust, and also a consultant obstetrician. And we're looking at improving access to the specialist trauma-informed support within Ocean for Urdu-speaking women and birthing people of South Asian heritage, and looking to give them that specialist support that they need and deserve. And whilst we've still got some way to go, we are seeing a much greater improvement in the diversity of our referrals in terms of people's ethnicity. That project has still got about another year to run, but we're continuing to work on initiatives such as a joint clinic where the Oceans specialism is provided within the antenatal pathways within Luton and Dunstable Hospital. We are looking to sort of run engagement events within our local communities and think about how our promotional materials can be more accessible. So I think that's all I need to say. I'll hand over.
Thank you, Amanda. Evening, everyone. I'm Liz Lees. I'm the... I just wanted to talk more generally about some of the structures that we've put in following the 2023 CQC inspection, where we got rated as inadequate. So one of the things that we did organisationally is we appreciated the scale of the challenges. As David says, we're one of the biggest maternity units in the east of England. In addition to that, we're also a level 3 neonatal intensive care unit. We're only one of 2 in the east of England. One of 3, sorry. So there's Luton and Dunstable, Cambridge and Norfolk and Norwich. So those level 3 NICUs take the sickest babies 22 weeks and over. So following the feedback from the CQC, we sought some additional support to come in to help us crystallise and frame that improvement journey. And we have got a really robust, we call it our perinatal improvement programme. It is a trust response, so this isn't something that we rely on just the service to lead. So I'm involved, non-executive directors are involved, the executive are involved, and the whole board are behind it. They participate and they have oversight of it. And we split it into 4 main things, mostly about strengthening safety, strengthening governance, culture and patient experience, because we know those were some of the things that came out of our CQC report. So we have got 4 very large work streams that have got daily and weekly activities and are tracking improvements against them. It's going to take time because there are multiple things to be done in that space, and as we've already touched on, in 21 days we move into a new acute services block, which is beautiful and will really enhance the experience for both our staff and our patients using the service. We had another CQC visit in July. They came on site for 2 days at both sites, both Bedford and Luton, and we're still awaiting some of the feedback on the back of that result. So from an improvement perspective, we are really supporting the whole service. The leads of all of those work streams, as I've described, are senior doctors from within the organisation that don't necessarily sit in maternity services, just to make sure that we are really getting it right in a sustainable way, so not just fixing it once, making sure that we can have some really sustained improvements for the service moving forward. Thank you.
Happy for any questions now.
Thank you. Just to say that we're grateful to receive the reports and appreciate all the hard work that's gone into producing it, and also all the hard work that's obviously going on at the moment to improve the maternity services at the Trust. So with that, I'll open it up to questions and comments from members. Councillor Steer.
Thank you. I think, David, you said it was the biggest in the region, and you said it was one of the biggest. Can you just give an indication of what big means? How many beds, how many births do you have on average in a day?
So, yeah, just there's two different things. The first is in terms of maternity. In terms of number of births, the Luton and Dunstable unit is the unit that delivers the most number of births per year. We have 5,200 or so, and that's the largest maternity unit. What Liz referred to was our neonatal units, and we have got a level 3 neonatal unit, which means we take the sickest babies, and there are 3 of those units: ours, Norwich, and Cambridge. I'm not quite sure how they're probably about the same size, I imagine, the 3 units. But in terms of maternity units themselves, I think the smallest I'm not sure what the smallest in the east of England is, but probably something like 2,000 births, isn't it? Or smaller than that, perhaps. James Paget is the smallest maternity unit, but ours is the largest. Whereas ours is 5,200. Yeah, James Paget is probably about 1,700 or something like that. Something of that order, anyway. But the interesting thing to know, and that's obviously in the report, is that most units are seeing reductions in births. So they've become smaller over time. And that's the case with, I think, all of the other units in the east of England, apart from Bedford and Milton Keynes. And that's obviously down to the fact that the fertility rate is so high. And I mentioned the fact that Luton has got the highest fertility rate in the country at 2, which is obviously driving some of that change, but also the fact that we've got a lot of growth in Bedfordshire. So whereas the fertility rate nationally is declining and other units are seeing big reductions in births, we're not. We're seeing stable number of births here.
Yeah, and presumably because it's a new unit, there is spare capacity in it. Oh, you laugh.
Not necessarily. I mean, one of the things about building a new unit is you have to build it to the sizes that we have, that we're required to. In fact, I think one of the statistics from our new unit is that some of the delivery rooms we have now are 3 times the size of some of the smallest delivery units in the current unit. Now, that's because of the kit, the fact that we need to make it as safe as possible to give the patient experience. So whilst the unit is very large, we haven't actually got significant additional capacity, and we haven't necessarily built for that. We don't expect the number of births in Luton to grow much beyond what we have now. So it's not that we've built for growth necessarily, but it is a much bigger unit because of the space requirements that we have. And obviously we've now designed in many things that we were missing in the old units, but in terms of actual number of deliveries, we're not expecting large numbers of growth, and that's not predicted by, I don't think your own public health team are not predicting large numbers of additional births, but they're not predicting any reduction either.
Chair.
Thank you. Councillor Moore, then Councillor Hussain.
So, firstly, you talked about, obviously, recruiting of midwives and things, and obviously the improvement in getting new midwives. I want to talk a little bit more about almost the other end of that, the retention rate. and how is the retention rate? Because it's great getting new midwives in, but they've got to learn from somebody, and having experienced midwives on hand will teach them and obviously give patients better rate of service. So how's the retention rate of experienced midwives looking?
Thank you, that's really important, and we do monitor that really, really closely. Our turnover rate is within a normal expectation. Our retention, we do have some people leave, but we feel that they're leaving for the right reasons. So we sort of tend to have a number who leave, and we leave not just outside of the trust, but perhaps go and work at Bedford. And then we have people from Bedford who come and work at Luton, because as maternity services, we're really quite integrated now as a senior leadership team. So we have people moving around to go and have different experiences in different units. But we do monitor that very closely. We undertake exit interviews, but before that we do have some legacy midwives. So these are midwives who perhaps are at the sort of other end of their career, who don't really want to leave, but don't want to be working so many hours, but have lots of leadership experience. And they provide us with sort of opportunity to go and work alongside other team members, but also provide a lot of pastoral support. So it is stressful working as a midwife. You know, it's quite hard work. It's a lot of emotional toil, and they have sort of cafes talking about you know, what interests you being in midwifery, what can we do to help develop you, and the feedback we've had has been really, really good from those. But work to do, but working well.
Thanks, Emma. Can I just add to that? What we did see just towards the end of the pandemic, because maternity services didn't stop in the pandemic, whereas a lot of services did, we did see quite a lot of burnout in midwives towards the end, and we did see people take earlier retirement than maybe they would have done if there hadn't been a global pandemic. So it has left a gap, and I think one of the things that we've had to do is really look at how we can do that differently to make sure that the new midwives that come into clinical practice, you know, get that development opportunity, that support opportunity, and that ability to develop and grow and become senior midwives within the service. But I think that has added to some of the challenges that we're left with, you know, immediately in the subsequent years after the pandemic. We did really notice that during that time.
Right, and secondly, obviously, there's a lot of talk in the report about the CQC report. Obviously, you've had 2 or 3 because of the initial thing. But with the move to the new building, obviously you won't know exact dates, because obviously that defeats the point of it, but you have an approximate timeline of when the CQC will be looking to inspect you once you're into the new building, because it'd be interesting to see how that would affect things.
Yeah, unfortunately we haven't got a time scale for that, and we do have regular engagement meetings with our CQC, and you know, we want to showcase the work that we've done. So as soon as we can get in and settled, all of the familiarisation is happening already. Staff are backwards and forwards, learning how to train and to work in the new environment, and they could come at any point. I'm sure it won't be long before they come to visit us again. Is what I assume.
Yeah, good. It's just because the last thing we want is you have to have 3 full inspections in the old building. We have this shiny new building, which obviously isn't going to fix all the issues, but then we'll have to wait 5 years, 3, 4, 5 years to see how that affects things. So
we've only
good to hear that one.
We've got 3 more weeks before we move into the new building. If everything goes to plan, we're planning for that. So I anticipate we'll be in before we have another inspection by the CQC. But we await their feedback from the July visit.
Can I just follow up on one of the points that Councillor Moore made about recruitment and retention? And how would you characterise morale in the maternity service at the moment? And do your staff have buy-in do you have buy-in from the staff to the training programs that you're implementing?
Again, another good question. So on a positive, with people going and doing the familiarisation, people are feeling buoyant about that and excited, and a bit nervous. I think we all feel a little bit nervous. It's going somewhere new. We're not quite sure what it's going to be like. People are working very hard, and it is very challenging. So at times, some people perhaps, but will tell us that things could be better, but they are telling us now what could be better, whereas before people weren't telling us. So they're talking to us and really engaging, and we have a really great maternity team and senior midwifery team, and our perinatal improvement plan, we have a lot of engagement within that plan with both frontline staff, our staff side representatives, and it's being led by colleagues who are outside of our department, so getting to know people and people like our Freedom to Speak Up guardians who people will go and talk to. So I think we're on the up as far as that's concerned.
I was just going to add, so one of my roles is I'm board level perinatal safety champion, so I do spend a lot of time on the shop floor along with my colleague Annette Gamble, who's the non-executive director perinatal safety champion. It is stressful for staff. It is an extremely busy unit, as we've described. It's very complex, it's very busy. What astounds me every day, though, is how proud people are to work there, and the ambition and the desire to deliver high quality care to the people that come through, despite some of the challenges. We have just conducted another workforce review to see what additional staff we need in order to meet the demand of the service, and we're just going through that process of reviewing that now.
Okay, thank you. Councillor Hussain.
Thank you, Jeff. Can I say to you right at the beginning, I mean, the actual inadequate report from the CQC was a major concern to the community. It was a real shock. As a previous governor of the L&D, when I saw those headlines, I just couldn't believe it. So taking that into one side, since the inspection, and you've said a number of improvements that have been made, but can I ask you, the first one is, in terms of recruitment, it is always difficult to recruit when there is when you have an inadequate inspection. I know that because we've gone through with the children's services in Luton, yeah? So it's not always that you get social workers that wanted to come and work for you. So how was your experience in terms of that, trying to recruit the staff?
So I'll take midwifery as an example. So we work very closely with the University of Bedfordshire. They're our local HEI. They train the midwife. They're obviously the people who we recruit are the majority of our new midwives from, and also University of Hertfordshire. So we work very closely with them. If they have a positive experience in training, they're more likely, completely accepting the inadequate rating. If they experience a positive practice experience, they will apply for jobs with us. That's what we have seen. Emma might want to come in there. I think if we're recruiting more senior midwives, from my experience, lots of maternity units are struggling. It's not just us, and I know I'm not suggesting for 1 minute that that's right, but lots of maternity units have been struggling up and down the country. When it comes to more senior midwives, we don't seem to have a particular problem in recruiting them, because I think the Luton and Dunstable unit has, despite the inadequate rating, has a reputation for being a good place to work and an exciting place to work as well, because not many units will have the complexity of the service that we provide, and that is attractive to lots of people as well. So I do accept that it could, be a bit off-putting going to an inadequate unit, but I think once we can describe what we're trying to do to improve it and them being an active part in that, I really think that goes some way to changing that perception that we want to move forward as well, to get us to where we need to be, so that people feel confident in coming to us, but also confident in working for us.
What is the position at the moment in terms of the recruitment? Do you have many vacancies, or what is it?
So with the pipeline, so we had 21 starting at Luton on Monday. Yesterday, went and welcomed them. I have another 9 staff coming over the next 3 months. We actually have some additional cover that we have for maternity leave, and it's some of the maternity leave cover, so that will leave about 11 vacancies, which out of just under 300 midwives is quite low.
And can you, in terms of the people of Luton and the children of Luton, in terms of safety, can you say that you have got now, since the inspection, there are major improvements so the children are safe, so the parents can really be assured of that? Because that was one of the concerns that many of the residents told me, when this thing come out. It was a real, very concerned, the safety of the newborn children.
Absolutely, and that's why one of the work streams in the perinatal improvement programme focuses on safety, and that is led by one of our most senior doctors in the organisation, who's a paediatrician. She's not an obstetrician, but she's a very well regarded paediatrician, and she is helping. One of her roles is to galvanise the teams in making sure that any actions we're taking around safety are embedded within the organisation. Maternity units are a risky service, and I think it is challenging, but it is one of our main work stream focuses on safety, as well as our people, as well as culture, and as well as governance. Do you want to add anything else?
Thank you, Liz. I just also wanted to assure you that in the last few weeks we have implemented the National Maternity Early Warning Score update and the Newborn Early Warning Score risk assessment updates as well, which are nationally recommended tools to use to detect deterioration. And we've rolled those out on both sites, and these will also be used in other areas outside of maternity services. As we stabilise ourselves and we get used to it, then it's an upgraded mechanism, and it will be used, for example, in the emergency department, or if a woman is being looked after, who's pregnant, is being looked after in another area, but it is felt by the obstetricians that they should have their observations charted on the maternity early warning score, that will be used as well.
And just in addition to this, because this is a really important safety element, we are currently still on paper in our maternity service. In February, we implement a digital system which will connect community, hospital, all hospital services up for maternity. So having a digital system embedded within the service also enhances the safety element as well, because it provides a platform where you avoid duplication, make sure records are all consistent across the service. So that is another thing that's coming. We wanted to do it sooner, but it's difficult to do a big transformational change like the moving into a new block and a digital transformation, because it is a big transformation. It's not just a change, it is a completely different way of working.
And did I hear right? Did you have a second visit from CQC?
Yeah, yes, they came in July. We haven't had the outcome for that yet.
You haven't had the...
No, we haven't had that yet.
No. I've got a couple of more questions, Chair, because it's one of the things that I did ask the committee to put it on the agenda for you to come, because it is a major, serious concern within the community in terms of the children's safety and the parents to be assured. So, this is something that's very close to me, because about 13 months ago, I had a grandchild. So that to me was at that time really panic to say the least. So can I ask you, in terms of the, allegation of racism, discrimination, which is what shocked me, because Luton is a very diverse town, and to find, racism in Luton and Dunstable Hospital was a real shock to me. Is that really, I just can't, when you've got such a diverse people working in the hospital itself, to find that there was a discrimination and racism? Is that a surprise to you, David?
I think it did surprise us because we pride ourselves on staff being able to raise concerns, and we hadn't heard those concerns come through. So it was not as though that we'd had concerns which we enacted on. Those concerns had not filtered through to us. But I think the work that we've done now is really encouraging that. But I think if you look at because we have some great information in terms of the National Staff Survey, and that's the NHS Staff Survey, Survey Staff, and it's currently out at the moment. But if you look at that survey nationally, it does show that there is racism in the NHS, and so I don't think we should be. I don't think we should not accept that it exists. But often it's not. We don't see it come forward. Staff don't feel confident in doing that. So I think one of the benefits now is it's opened up that conversation, and I think it shows us how complex that is. There's certainly both staff who receive racism from patients, and there's also staff who receive racism from each other. But recognising that we are a very, very diverse staff group as well. We have over 100 different countries represented in our staff group, so we've got one of the most diverse staff groups in any NHS organisation. So, but I don't think that means that racism isn't likely to happen. We know that it is a real factor in both in society, and that is then also reflected in our hospitals. But I think the fact that we've been able to talk about that in a very open way now and allow staff to come forward. But I think we've got real mechanisms for and staff feel confident in raising those in a way that perhaps they didn't in the past.
Have we seen any changes in terms of that since the CQC visit and the second visit? Is there major changes in terms of that, or are we seeing improvement?
I think for me, we have 10,000 staff in the organisation, and therefore we will always anticipate that there will be issues that arise with that number of staff. What's important for me is that when things happen, staff feel that they can raise them, that they can escalate them, and then we can deal with them. What's a problem is if staff don't feel that is the case, and then things don't get escalated. So I think with the number of staff that we have, I think we'd always anticipate that there'll be pockets of problems that occur. I think what's important is the understanding where those pockets are. Staff feel that confident they can raise it internally to the organisation rather than externally. That's a sign of failure when staff feel they have to go outside to raise it. And I think we are seeing that happening in the organisation. So I think it's not. I think it would be unrealistic to expect that we never have issues of racism in the organisation. What is realistic to expect that staff can escalate when it happens and that we can then deal with it. And I think that is the case in the organisation.
As you said, I think in answer to my colleague, in terms of the number, there has been more growth in children birth in Luton than the eastern region as a whole. Do you have sufficient, in terms of the staffing level, do you have sufficient people who are now to be able to, deal with the growth in the birth?
Well, we haven't seen in Luton, in the Luton and Dunstable unit, a very significant growth in numbers of births. But what we think we've seen is a growth in the complexity of those births. And so, for example, the fact that we see now more women who give birth at an older age. Now that brings complexity, that brings more challenge, that brings more risk associated. We've seen over the years women give birth with a higher BMI who are more obese, for example. we've seen a growth in women who perhaps don't have English as their first language, which creates, again, a bit of complexity. So I think the background to the challenge we've had at Luton is not necessarily caused by a growth in number of births, but it's been a growth in complexity for all of those different reasons, which when we put them together, and I'm absolutely sure that whilst Luton and Dunstable has the highest number of births in the East of England, it also has the most complex births in the East of England because of the population we serve and the fact that we have a Tier 3 neonatal unit, which also means we bring in high-risk births from other units. And it's that story combined with the fact that we've had, as Liz mentioned, through COVID, the early retirement of many experienced midwives. Those two factors, the complexity of the women and perhaps the less experience of the midwives and the doctors have been the story that's caused that. So I think what we've recognised, and Emma referred to this, is the fact that actually we need more staff per birth than the average unit because of the complexity of our women. And that's the bit that we're trying to now reflect in terms of making sure that our staffing not just meets the standards, but actually goes above that, because I think that's what's needed. The other factor that's been a really, really significant factor is the level of caesarean section, which has happened across the country, is that now the caesarean section has gone from closer to 20 to nearer 50% for various different reasons. And that also increases the difficulty, because if a woman has a caesarean section, she's staying in for longer. So the amount of resources is needed. It needs theatres to service that. So it's a much more complex birth, a caesarean section, than a natural birth. So all those factors together, going back to your point, do we have enough staff? Actually, we are looking at the moment at, we've just done a workforce review, and we need to increase that number of staffing. There's no doubt about that, in order to cope, not with the increase in births, but the increase in complexity of women, and particularly the caesarean section, which has driven a higher number of resources than otherwise would need. If that caesarean section is now getting close to 50%.
Is there an increase in stillbirths? There was an issue in Luton, particularly in stillbirths, among a certain community, particularly in the Asian community. Is that in the increase, or is that a decrease on the stillbirths?
Well, the Embrace data monitors that's the people who calculate the data of the stillbirth and neonatal perinatal mortality. And clearly that's a factor in Luton, that we have more complex births, issues of consanguinity, for example, and that does drive the complexity. So again, that's another factor, which means that our births in Luton are more complex than in other areas.
Thank you. Councillor Latif.
Thank you, Chair. So thank you for the report, and it's obviously exciting times moving to a new building, so hopefully that all goes well. I just want to revert back to the CQC inspection back in June of this year, and it mentioned a backlog of incidents. Can you just elaborate on what sort of instance you're referring to?
So we have an incident management system, and we follow national standards for that. And it can be many different things. So it could be an incident of a broken piece of equipment, or it could be an incident relating to somebody not getting pain relief, or it could be an incident that is somebody has had significant blood loss. So it could be various, anything. It could be about lots of different things, but we have a process whereby the incidents are submitted, and they're submitted electronically, and every day we have a multidisciplinary team who's reviewing those incidents straight away to understand how they've been graded. Does it need further looking into immediately, or what do we need to do? And we do that every day, not on a Saturday and Sunday, but again on Monday. And then we follow the National Patient PSAF incident framework through the Trust. So any incidents that are graded as being moderate are then reviewed outside of our department, and we take it to a Trust panel where either Liz or the medical director sits on it, and we then review using this framework as part of our processes as well.
Another question, please, Chair. Thank you. Just want to understand, obviously I welcome the new recruits started yesterday, so yeah, that's good news. So I understand the relationship between obviously permanent staff and the use of agency staff. I wonder if you can elaborate what sort of percentage are we talking about in Luton Dunstable Hospital?
We actually use very few agency midwives. At the moment, we probably have about 5 midwives who are agency midwives who do regular agency with us and are almost like our own staff really, but choose to work in that way. And our teams welcome them, get to know them as any new people. So we have good relationships. We do a specific induction program with any agency staff, and they work alongside as colleagues. So we'd expect those relationships to be good. And not just for midwives, but, you know, we need to think of, we do use locum doctors as well. And it's not just about midwives, it's about a multidisciplinary team.
Thank you. Councillor Riles, go ahead.
Okay. Hello. Thank you for your report. It's very detailed. Thank you. I just want to ask about the services, you know, the trauma services, and how joined up are they together when they have to, obviously, a person may come in, mother presents. How joined up are they with the surgeries, the doctor's surgeries, to provide, you know, so that they may have a problem and it's identified when they're at their GP surgery, and then obviously notes are made when they come into the hospital. But how joined up and how much follow-on is provided for that? Thank you.
Thank you. I think that's a very interesting question. So during the pregnancy pathway, we obviously are caring for women during that episode of care, and we recognise that their GP will be caring for them either side of that and through it. But generally speaking now, GPs don't do a lot of maternity care during where they might have done some years ago. So our communication with GPs is really, really important, and we work with their liaison committee. We're working with them at the moment about some challenges with electronic records and those sorts of things. So, you know, I think it's about opening those and maintaining those communications with the GPs. The midwives, some midwives still work in GP surgeries, but we do work in more of a hub-based location. But the GPs will know contact details of the midwives and will be able to, you know, have communication with them. And we do it also through our sort of like, we used to call it GP liaison, but committees that are run by our ICB that we partake in as well.
Can I just ask, I just want to find out if, for instance, if somebody hasn't been engaging with the hubs, okay, and they come in, present, and they are in labour, how is that managed?
Well, I think all of our maternity care is really about risk assessment, and that's not just about physical risk assessment, it's about other things as well. So you would also automatically have an alarm bell ringing if you're seeing somebody who's heavily pregnant, maybe in labour, and they've not had any antenatal care, for example. You'll be immediately asking yourself, why is that? Is that because they've not been able to access it? They don't want to access it? And so we have sort of a mechanism through our risk assessment, our safeguarding and our well-being to understand how we can support women and how we need to protect vulnerability as well, both for them, their unborn baby, or the babies when they've delivered. So we have really good and strong safeguarding mechanisms for our most vulnerable patients as well in place.
I just need to ask also about, as my colleague raised, about the diversity, the training for the midwives. Obviously when they're at university they have training, but when they actually come into the hospital, how much diversity and inclusion training do they receive, and how regular do they receive it? And what are the mechanisms to actually assess that they understand and appreciate different cultures, different backgrounds.
Again, a really good question, and one that we're working really hard on. So we know that we can do more and that we need to do more, and our sort of cultural awareness training has been really important to us, and we've had quite a lot of midwives. I think just under 100 have been through that training. But looking at different ways of doing it, and it's not just about everybody attending a course for that to make a difference. And we had lots of discussions about this when the feedback was given to us about staff reporting discrimination. And that's a lot of the work through the work streams and through our diversity and inclusion networks, working with teams, understanding how people are feeling, engaging them in our charter, the way that we're going to work. This is how we're going to work, and there's always more that we can do. Liz, you might want to.
Can I ask, please, that we are presented with some figures also, please, so that we can actually, because obviously where we can have a look and analyse ourselves, and also the diversity of the senior management team, the midwifery team, and the board team as well, please. Can we see some figures on that as well, please? Because that makes it important, because it's fed down from top to bottom. So it, needs to be broad-based so that you have a good cultural mix, and so that you can, sometimes we all learn from each other, basically. Thank you.
Thank you, Councillor Isles. Could I just follow up on the points that several members have made about trying to tackle the racist attitudes. Is there a recognition within the service that that such attitudes can harm mothers and babies at the point of childbirth? And does the training, the diversity training that you're instituting, does it cover that aspect?
Sorry, could you repeat that?
Okay, so there's documentary evidence that birth outcomes have been affected by racism, by racist attitudes. Is there a recognition within your service that can happen, and does the training reflect that?
I think, as David touched on, we absolutely, our staff told the CQC around their experience, so we work on the assumption that could happen. And just picking up on the point Councillor previously made around equality, diversity, inclusion, which is a whole range of activities. We've got our EDI leads in the organisation have co-produced an anti-racism charter with our staff. The next component of that is really making sure our cultural competency, EDI training is really fit for purpose, so it covers all of those things. We are making sure we collect more data on our, and the digital the digital platform that we're implementing will help us capture that more and triangulate that more robustly. But we continue to monitor and work around that to make sure that everyone has a good outcome when it comes to having a baby, to keep them safe, because it's all linked to safety, and we absolutely recognise that as an organisation. So work will continue on that. And I think around stats around our EDI training, we can bring that back at a later date and see where we've got to. This isn't just for maternity, this we recognise that we have to do this for the whole organisation. Because, as David says, we have got a very diverse staff group as well as patient group. Thank you.
That's reassuring. For getting on to the the statistics. So what sort of data do you collect around childbirth and birth trauma and outcomes? I mean, for example, is it possible to collect a number of is it possible to define an avoidable birth trauma, and is that the sort of information that you would collect?
So when we have, going back to how we manage incidents and level of harm, so we report a high number of incidents, particularly in maternity, but we're every month. Now that is a positive thing, because a good reporting culture means staff are reporting where things could have gone better or might need investigating. So every day in maternity, all incidents from the previous day, because there will be a number of them, are reviewed. If they reach a threshold for moderate harm and above, they come to a panel that myself or the medical director chair once a week for review to see what action we need to take to investigate it. And then we have multiple tools that we can use. Some of them will reach a threshold for an MNSI investigation. So if they reach that threshold, that is an external review. So we're not just marking our own homework when it comes to investigating things where there's been a poor outcome. So there is our staff are involved, but it's led by a component of the CQC essentially, who will conduct that report for us and provide us with a review and any recommendations that come out of that. Then that is then used, along with all our other incidents, is to make sure we've got that organisational learning embedded as a consequence of things that could have gone better.
Okay, thank you. I think that brings me on to onto my next question. So as you've just gone into quite some detail there. I think it would, in the report mentions the perinatal improvement programme. I think it would have been useful for us to see that as an appendix to this report. Not just for ourselves, but then it would have been in the public domain as evidence that a serious improvement plan is in place. The section titled Investment in Training and Clinical Standards, that states that the plan incorporates all CQC action plans and that new training programs are aligned to national frameworks such as the Ockenden recommendations. So if we had sight of the improvement programme, then we could see for ourselves whether that aligned with Ockenden. I think that's important because the recommendations of the Ockenden reports, if implemented, would provide a sound basis for a successful perinatal programme, and it would just be confirmation that that the plan is the right one, is on track to give you the improvement that is needed. This is just a question about the use of the word alignment. I mean, that suggests to me that the improvement programme is not necessarily implementing those recommendations in full. I mean, is that the case? For example, one of the recommendations is that the maternity service should work with the trust board to produce regular progress and exception reports. I think you've perhaps already said that does happen, that there is that sort of regular review.
Yes. Sorry. So there's a couple of things I can add to that. So absolutely happy to shape that in a way that would be more meaningful for this committee. There's a lot of activities in those perinatal, there's hundreds and hundreds, not things of recommendations, but things that we want to do to improve the service ourselves. We've put in we've put in an additional organisational meetings for oversight of maternity over and above our quality committee, which is the board subcommittee, and our board, because I think we have to recognise the volume of things that are required is vast. So it helps us keep it in one place rather than having a CQC action plan, an action plan, you know, lots of different action plans, because I think if you have lots of different action plans, you can easily lose track of where you are with them. So that the good thing about the perinatal improvement programme, and we'll try and ensure that we can demonstrate that for you, is that it encompasses all of those things. So if there's an activity that needs improvement, it is in the perinatal improvement plan somewhere, regardless of whether it was an OCADM recommendation or a CQC recommendation. Does that answer your question?
Yes, I think it does. Yeah, yeah. So yeah, so yes, if we could, I don't know if we can add that as an appendix to the, yeah.
Yeah, we can get that to you. Yeah.
That would be great. Thank you. Okay. Talking about metrics and indicators, I mean, how will you judge the success of the program? What sort of metrics, what sort of indicators will you be looking for?
So we're still working on that. So I think the bit that we're really trying to focus on, which I think lots of organisations have struggled with, where there's a recommendation, it's getting it to a place where it's complete but sustained. So we are still working on all of the metrics, the nuances in the within the perinatal improvement programme, and we've got a programme director helping us with that who's skilled in programme management. So we've got that measurable, sustainable bit, which is slightly different than making something go green on an action plan. So we are we're working through what some of those metrics look like, and I think, if I'm right, Emma, some of those metrics have just been shared with the clinical leadership team in maternity to test them on whether they. So we're not quite there with that. What do all of the suite of metrics look like to say this has been successful? Because one of the challenges we've only had the programme up properly since February. It's getting all the activities and all the right people in the right place in order to drive those improvements. And the bit we're working on now is making sure those measurable improvements are there, achievable and sustainable, and are monitored. So even when our improvement teams step out of the organisation, this is just business as usual for us as an organisation, and the infrastructure remains.
Okay, thank you. Just one last question. It was in the press last week about the legal claims that have been settled, and that it was total £17 million in the year 24-25. Presumably that is that's not just for incidents that have happened in the past year. That's over the past few years. And does the payout of that money affect in any way the resourcing for the maternity services going forward?
So I can just answer that. So the way that it works in the NHS is that effectively the NHS self-insures. So we pay effectively, basically like insurance premiums that are paid to a big pot. And for most trusts like ours, maternity is always by far the most significant element of that. And that's because obviously a single case can result in sometimes often up to £20 million if you're eventually a case is settled, for example, following a birth that might end up with cerebral palsy or another outcome. Obviously those cases usually take long time to settle in any case and go back many years. So in answer to the question, what comes out of our budget as an organisation is the premiums every year for the litigation, and that premiums are also take into account your the extent to which you've put in place actions in order to prevent that happening. A bit like normal insurance. The only difference in the NHS is it's self-insured. It's not through a private industry. The NHS self-insures. So we pay the premiums every year, and then when the claims are settled, they're settled by the NHS Litigation Authority, not by the trust. We pay the premiums to the NHS Litigation Authority. That's the way it works. But as I say, maternity is by far, for every trust in the country, maternity represents the most significant cost in terms of insurance premiums for clinical negligence because of the impact if one case goes wrong.
Okay, thank you. Does anyone else have any questions or comments? Okay, Councillor Hussain.
Once there is the second visit, you know, the conclusion of CQC, when the result of that, we would like you to come back sometime in the future, yeah? Is what the feedback and what their opinion and how things have gone on in terms of the improvement. That would be very helpful to us to be able to see the second visit of the CQC.
So when we're talking about the second visit, is this the results of the visit that occurred
in July,
the summer?
I think, yeah. We haven't had the report, but when the report is published, it will be in the public domain anyway, but we haven't had the report. But when it does come back, we'll obviously be happy to come back in terms of whatever the report says, but also our actions in response to that.
Okay, so when would be... so you obviously need some time to, before you come back to us, it'd be good if you had some time to take on board and respond to those findings and recommendations. And also, would it be wise for you to bed in your new premises, your new buildings before you come back? Because that's, from what you're saying, that will have some impact on the quality of the services you provide. So perhaps some point after that, in 9 months or 12 months' time, does that seem?
That'd be absolutely fine.
That seem reasonable?
Yep.
Okay, thank you. So I think just to sum up, there's from what I've seen in this report and what's been said this evening, there's a recognition of the issues involved and that there's a serious and systematic effort to going on to tackle these issues. And hopefully in the future we'll get some indication that some real progress is being made. What you said tonight, it seems promising. I think that we need to know that the key developments listed in paragraph 4 are being implemented effectively, and we need to see metrics and indicators showing that they are working effectively. As we just mentioned, it'd be good if you came back to report on progress, I would say in 9 months' time, if that's okay with you. Okay, thank you very much. Thank you. We haven't finished yet. Okay, just one more item to consider. That's the draft work programme. Just to let everyone know that I have a meeting with Democratic Services and Corporate Director, Population Wellbeing, and Service Director, Public Health, and the Director of Added Social Services to sort out, finalise the work programme for the next few months. So if any members have any items that they wish to add to the work programme for consideration, then let me or let Nazat know about that. Okay, thank you. That concludes the meeting.